Dear colleagues, at the beginning I would like to thank Professor Didi Morel, who invited me to her session to give an introductory overview of autoimmune blistering diseases. When we speak about classification of autoimmune blistering diseases, we always speak about intra and subepidermal diseases, and regarding this subclassification of each of those groups, there are some revolutionary novelties in the last few years, although whenever there is research around, we could expect some new subdivisions. All these diseases are a result of autoantibodies that are directed against different parts of desmosomes and parts of basement membrane zone, and each of autoantibody is directed to particular target. When we speak about autoimmune blistering diseases, we speak about rare and very rare diseases. Here, from the research that was performed by Sinead Langen in 2008, we had information about pemphigus that appears in 1 to 1.7 new patients per 1 million inhabitants a year, or bullous pemphigoid with 5 to 30 new patients, although for pemphigoid there were some data about that disease is a little bit more common. When we speak about pemphigus, there are some new data that were published and compiled in an article from 2021, where we can see that in different countries data really differs. If we go to the Northern Europe, then these numbers are much lower. If we go to the south, to the Mediterranean part, especially to Israel, then the incidence is really much higher. But we have information, we have data about increased incidence rate of bullous pemphigoid, and quite often we ask ourselves what happened, why there is increasing incidence rate. Is there because we have new, more precise diagnostic tests, or we have new atypical forms of pemphigoid, or we have the knowledge about the drugs that are triggering disease, or just because of aging of the population? I would say that correct answer is because of all of that. We have also to keep in mind so-called non-bullous pemphigoid that, according to some references, appears in about 20% of all bullous pemphigoid patients. My personal experience is not that we have so high numbers of non-bullous pemphigoid patients, but of course in countries where the research and systematic research was performed, data are very clear about it. Before starting any therapy, we of course have to perform diagnosis with history, clinical picture, histopathology, direct and indirect immunofluorescence, and ELISA. For some difficult to diagnose or difficult to differentiate autoimmune blistering diseases, immunoblotting can be performed. There is a series of guidelines that were published by different groups, by task forces, by group of experts, and some of them are guidelines, some of them are recommendations. Of course, they differ because from continent to continent, from country to country, because healthcare conditions and modalities are different among European countries and, of course, between different continents. There are different hospitalization rules, home care availability, and also possibility of reimbursement of different systemic treatments or also topical treatments. So that is the reason why we have to, when we are reading those guidelines, we have to keep it in mind. But in all guidelines or recommendations, there are major objectives that are common: to confirm the clinical diagnosis, to search for risk factors, severity factors, to specify initial involvement and extent of This involvement to evaluate prognosis depending on general condition, to measure extent and distribution of the lesions by different tools, and of course then to start treatment. Each diagnosis starts with history of disease and clinical picture. Of course, we are looking to blisters, are there tense, flaccid, or is there erythematose, inflamed skin or non-inflamed skin, distribution on skin or mucous membranes. We also perform Nikolsky test, although it is not of such big importance as it was in the past, but it's very useful clinical test. Speaking about pemphigus vulgaris, it usually starts on buccal mucosa. It is very common site. But on oral mucosa altogether, it starts about 60 to 70% of patients, and then later lesions on the skin develop. They can develop on entire skin, on some parts of the skin. Also, scalp should be checked because it is quite common that we find some of the lesions on the scalp. We have patients, we all have seen patients with affection of almost entire skin. Maybe in last year we have seen a little bit less of those, with exception during the COVID period where patients were a little bit scared to go to the hospital. Then we have seen some of really very severe clinical pictures. Affecting nail is part of clinical picture of pemphigus. From our experience, it's usually affected in a little bit more severe pemphigus variations. Speaking about pemphigus foliaceus, main difference is that the blisters or separation is superficial, and in pemphigus foliaceus there are no mucosal lesions. Bullous pemphigoids can start with these non-bullous lesions, and then after a few weeks blisters develop. They are usually tense blisters, but of course, as I mentioned, in some of patients this non-bullous pemphigoid persists with more eczematous lesions. Linear IgA dermatosis, which was in the past called chronic bullous diseases of childhood. Today we know that it appears also in adults with a little bit different clinical picture, but this picture on this slide is one of the common clinical pictures for linear IgA disease. This is EBA, acquired epidermolysis bullosa, which is a little bit linear IgA like EBA in our young patients. Or dermatitis herpetiformis during, which appears on extensor sites of extremities, but also on the trunk. What is typical, we rarely see blisters because it's very itchy and patients usually scratch blisters. When we start with the diagnosis, we start with histopathology. Although histopathology doesn't give us usually final answer, we have to perform biopsy from the correct place. And here is a picture of that, and I think that this public doesn't need very detailed instructions because most of you know how to perform biopsy for autoimmune blistering diseases. This is for histopathology, and the other biopsy should be taken a little bit away from the blister for direct immunofluorescence. In the past, some of us used to do one biopsy and then split in two parts, but we know today it is really not very useful because we can mix it and then get completely different and unreliable results. Direct immunofluorescence is very important and gives usually very precise diagnosis. For indirect immunofluorescence is also very useful to know what is our working diagnosis. Is it intra or subepidermal blistering disease? And according to that, we can choose which substrate we use for this investigation. Is it Guinea pig or monkey esophagus, or human skin, salt split skin, or rat or monkey bladder? specifically for patients with suspected paraneoplastic pemphigus. Split skin gives additional data, especially for patients with, of course, it's used in patients with subepidermal blistering disease, and we know that on epidermal sites we will find deposits in patients with BP, with MMP or linear IgA, and on dermal sites with EBA or P200 pemphigoid. ELISA is also a very useful test. Today we have a number of commercially available tests, and BF-chip is also one of the tests that can be used maybe more commonly in labs without very big number of sera, but it can give quite quick answer to our doubts. Regarding therapy, I will not go here in details, because after this introductory talk there will be a series of lectures from my dear colleagues that will speak about different diseases. I will mostly mention some of the guidelines that were issued by task forces of European Academy of Dermatology and Venerology since 2020. But as I said, in details, all these treatment options will be discussed in following lecture. In 2020, guidelines for pemphigus were published with rituximab as first-line therapy for mild and moderate and severe pemphigus vulgaris, and also for moderate and severe pemphigus foliaceus, and all other therapeutic options are described. Quite recently, in 2024, Pascal Joly and his group published an article in JAMA Dermatology about biomarkers as predictors of short-term and long-term relapses, because there were some discussions: is rituximab enough or not? Should it be given more often or less often? So Pascal Joly will for sure speak about it in his lecture. We should never forget additional supportive treatment that also increase quality of life of our patients. Regarding bullous pemphigoid, there are also a few lectures about treatment of bullous pemphigoid, and our group published guidelines in 2022. We have here older patients with significant comorbidities, which they are usually dependent on relatives or nurse home care. Here there are recommendations about therapeutic options really very clearly stated, and it will be stated also in following lectures. Also in one lecture speaking about therapies that are in pipeline, and we are very curious to hear what is already on and what we can expect from some of those drugs. Never to forget skin care, local therapy. There are also guidelines on dermatitis herpetiformis from 2021. No too many novelties, mostly defining dapsone and gluten-free diets that should be therapy of choice for those patients, with some options in patients that are that cannot take dapsone, that have some allergies on non-tolerability. There are also guidelines for paraneoplastic pemphigus published in 2023 with very detailed algorithm how to investigate those patients, how to come to the final diagnosis, also with recommendations about treatment options for those patients. Last guidelines that were published were those on linear IgA dermatosis that were published in 2024. Also with really clear algorithm how to confirm the diagnosis of linear IgA dermatitis, and with recommendations how to treat those patients as first-line dapsone with or without topical corticosteroids, with all other therapy options, with some detailed information what should be done and what should we take care of in patients on dapsone. What is the future? We know that incidence is rising. as the population ages, that we have quite good tests, but we are still waiting for some specific and well-tolerated therapies for all groups of those diseases. I would like at the end to invite you and to recommend you to, especially for EADV members or those who are not members, to join the Academy. There are a series of different courses. One that I can recommend connected to this lecture is this on Introduction to Autoimmune Blistering Diseases. And also at the end, I would like to invite you to EADV Symposium next May in Prague, this May in Prague, or in Paris in September this year. Thank you very much.
Hello everyone, and thank you very much Dede for giving me the opportunity to discuss with you today a question which is not too often discussed. Who gets pemphigus and why? I guess there is really no need to introduce pemphigus vulgaris to this audience. So the question we would like to address during the next 15 minutes or so, who gets pemphigus and why, relates, of course, to the etiology, to the pathogenesis of pemphigus vulgaris. Now, every resident, I guess, knows very well the basics of pemphigus pathophysiology, where those basics were put forward by John Stanley, Masamagai, and many others a few decades ago. And according to what can be referred to as a kind of a central dogma in pemphigus vulgaris results from the deleterious effect, the destabilizing effect of autoantibodies, which are directed against different desmosomal components, such as desmoglein 3, desmoglein 1. And those effects are deleterious actually to cell adhesion within the epidermis. Those antibodies actually affect the stability of the desmosome, which eventually leads to intraepidermal blistering. Now, according to this theory, those anti-desmoglein 3, anti-desmoglein 1 autoantibodies are not only necessary, but actually they are sufficient to lead to the disease phenotype. But over the past few years, this picture has become much more complex, with a sharp increase in the number of target autoantigens and in the number of pathomechanisms now known to be involved in the pathogenesis of pemphigus vulgaris. And there are many clinical cases which are apparently contradicting this central dogma, and this is still, by the way, an evolving issue. Now, you will hear over the next hour or so several lectures on various ways, various strategies to treat pemphigus and to treat other autoimmune bullous diseases. Now, these strategies all share in common the fact that they target various functions of the immune system. And this, as we will hear, will always come, of course, at a certain price, mainly opportunistic infections. Now, one of the main paradigmatic change in our understanding of the pathogenesis of pemphigus vulgaris over the past 5 years, which may translate into a paradigmatic change in our approach to the treatment of this disease, has been the recognition of the role of epidermal non-immunological elements in determining who will get pemphigus and who will not. And here too, it takes two to tango. These insights actually stem from the study of the genetic basis of pemphigus. Now, while speaking about genetics in the context of a late onset acquired disease like pemphigus vulgaris, well, there are a number of facts which initially suggested that pemphigus vulgaris may be at least in part genetically determined, including reports, first of all, of familial occurrence, the presence of autoantibodies in first-degree healthy relatives of patients with pemphigus vulgaris, and of course a very strong ethnic propensity, the disease being up to 10 times more common in the Jewish population as compared to other groups. Now, if you are dealing with multifactorial diseases, the way to go in order to delineate the genetic basis has been for many years now the so-called association studies, in which you look for genetic variations which are more or less common among a large group of patients as compared with a large group of healthy individuals. Those association studies have been used extensively to identify genetic variations conferring an extra risk for pemphigus vulgaris and other forms of pemphigus. Now, there are two major forms of association studies. We have those candidate gene association studies in which we are looking for variations in genes which encode molecules which are suspected to have something to do with the disease under study. And those have revealed a large number of risk variants in immune functions encoding genes such as HLA genes, in genes encoding cytokines and other molecules of relevance to immunity, as well as genes that are coding for autoantigens. But the major problem with this type of study is that they will often point at genes which are coding for elements which are already known to be associated with the disease pathogenesis. And in contrast with candidate gene association studies, genome-wide association studies, the so-called GWAS studies, do not suffer from this disadvantage, but they are much more demanding in terms of resources like the number of participants required to achieve statistical significance, and this can be, of course, a big problem in a disease as rare as pemphigus vulgaris. Now, we nevertheless used this approach in a cohort of Jewish patients and identified a number of genetic variants in the vicinity of a gene called ST18, which were found to be associated with the propensity to develop pemphigus vulgaris. Who is ST18? Well, ST18 is a transcription factor which is putatively associated with the regulation of inflammation and apoptosis. And the variants located around the ST18 locus were found to confer a 6-fold increased risk to develop pemphigus vulgaris, which is really a lot in this type of studies. But not only a risk to develop the disease, but also a risk to develop a more severe disease, as can be seen here. Now, variants at the ST18 gene locus were found to be associated with an increased risk to develop pemphigus vulgaris in some, but not in all populations. And it seems actually that genetic variations in the ST18 gene may explain the higher propensity to develop the disease in patients originating from the Middle East area. So this suggests that pemphigus vulgaris, at least from a genetic point of view, may be a different disease in different populations, which of course is about genetic risk variants as druggable targets. And this is not only true of ST18, but also, of course, of other genetic variants, such as various class II HLA genes. Now, despite the fact that the association between genetic variations and the ST18 locus and the propensity to develop pemphigus vulgaris were strongly established, not all associations will necessarily reflect a causal relationship. And to look for a functional connection between ST18 and pemphigus vulgaris, we used deep sequencing of the pemphigus vulgaris associated locus. And using this approach, we identified almost 800 variants in the region of the gene which were found to be associated with pemphigus vulgaris. And among those 800 variants, one of them was found to be specifically associated with pemphigus vulgaris and located within the promoter area of the ST18 gene. And this variant was interestingly found to result in marked activation of the ST18 promoter, which actually is predicting increased expression of ST18 in the skin of pemphigus vulgaris patient. And indeed, by immunohistochemistry, they were able to show that ST18 is strongly overexpressed in the epidermis of pemphigus vulgaris patient. And ST18 overexpression, by the way, was not noticed in lymphocytes or in the dermis, was only found in keratinocytes. Now, the question is whether increased expression of ST18 has anything to do with the clinical manifestation of pemphigus vulgaris. Does increased expression of ST18 contribute to blister formation? And to address this question, we used an assay called the B-space dissociation assay. What is this assay? Very simple. Actually, this assay measures the strength of cell-to-cell adhesion in the epidermis. What you do is very simple. You grow keratinocytes in a petri dish. They form epidermal sheet. Then you use an enzyme called B-space in order to disconnect the epidermal sheets from the bottom of the plates, and then you expose those sheets to some form of standardized mechanical stress. And this will lead to fragmentation of the epidermal sheet, especially in the presence of autoantibodies obtained from pemphigus vulgaris patients. And then you can measure the number of fragments, and this will give you an estimate of the adhesion strength. The more fragments you get, the lower the adhesion strength. So when we overexpressed ST18, we got many more fragments. And this indicates that the ST18 variant causes increased ST expression, which actually contributes to epidermal acantholysis and to skin blistering. And the question, of course, is what is mediating this effect? And it appeared, and this is really cutting a very long story short, that ST18 induces the expression of a number of pro-inflammatory cytokines, which include, by the way, TNF-alpha, and those cytokines are known to increase the propensity of the epidermis to undergo acantholysis, destabilize cell-to-cell adhesion junction. And what is quite interesting is that regarding the involvement of TNF-alpha is that neutralizing antibodies to TNF-alpha almost completely abolished the effect of ST18 on cell-to-cell adhesion in the displaced dissociation assay. Now, not only was ST18 overexpressed in the pemphigus vulgaris epidermis, this was much more prominent in, as you can see here, in the epidermis of a carrier of the ST18 risk variant. And this correlated with TNF-alpha expression in the epidermis. In short, it seems that ST18 overexpression contributes to pemphigus vulgaris pathogenesis and to the risk to develop the disease. Now, a major aspect of the pathogenesis of chronic disease like pemphigus vulgaris, which is very often overlooked, is what is actually underlying their chronicity. What is the cause of, what is perpetuating the pathogenesis of pemphigus vulgaris, transforming an acute event into a chronic process? And recent data have actually uncovered a cyclic mechanism which may explain pemphigus chronicity. And at the core of this pathological cycling mechanism, we have three major elements: ST18, desmoglein 3, and P53, which seem to cooperate in order to perpetuate the deleterious effect of those pemphigus vulgaris autoantibodies against desmoglein 3. Let's now see how and why. So first of all, we found out beforehand that ST18 contribute to desmoglein 3 downregulation, which of course may in turn further aggravate cell-to-cell disadhesion, and this is very nicely shown here. Anti-desmoglein 3 antibodies result in decreased expression of desmoglein 3 on the membrane of the keratinocytes, and remarkably, ST18 was found to enhance autoantibody-mediated desmoglein 3 downregulation in keratinocyte, as shown here by the white arrows, which may contribute to decreased epidermal cell-to-cell adhesion and acantholysis in pemphigus vulgaris. We actually confirmed this data at the single cell level. In other words, those cells which were found to overexpress ST18 were those showing decreased membrane desmoglein 3 expression. And vice versa, those cells expressing low level of ST18 were found to express high level of membrane desmoglein 3 expression, and this was found when quantified to be significant. And this brings us to our third element, P53. What is P53, which is of course very well known to us as dermatologists in the context, for example, of non-melanoma skin cancer? What is P53 doing here in the context of pemphigus vulgaris? So you may remember that the ST18 variant, which we identified within the promoter of the ST18 gene and confers a 6-fold increase risk to develop the disease, induces the expression of ST18 and explains ST18 overexpression in the skin of pemphigus vulgaris patient. Now, to cut another very long story short, it turned out that this variant is critical for the binding of p53 transcription factor to the promoter of ST18. And in fact, elimination of p53 abolishes the ability of the variant, of the risk variant, to induce ST18 activity. We found out that decreased desmoglein 3 expression using different method induces p53 expression, as you can see here. And not only was this shown in vitro, but actually in patients, in the skin of patients, p53 expression was elevated in the skin of pemphigus vulgaris patient, and even more so in carriers of the risk variant in ST18. Now, the question is, of course, whether p53 upregulation has any effect on the expression of ST18. And quite interestingly, we found out that pemphigus autoantibodies induce ST18 activity in a way that is dependent upon the presence of p53, because downregulation of p53 abolishes this effect. And this is actually closing completely the loop. Now, sounds complex, but actually it's very simple. Let's try to summarize what we have been going through so far, and to integrate this data and figure out how immunological and epidermal elements contribute together to the pathogenesis of pemphigus vulgaris, and those so well beyond the classical model linking anti-desmoglein 3 antibodies to blistering due to acantholysis. Here we have shown that variants at the ST18 locus are leading to ST18 overexpression, and this in turn leads in destabilization of epidermal cell-to-cell adhesion due to the secretion of a number of pro-inflammatory cytokines, including TNF-alpha. ST18 also leads to the downregulation of desmoglein 3 expression, which has two major consequences. One, further destabilization of cell-to-cell adhesion, and two, induction of p53, which in turn further upregulates ST18, thereby setting the stage for a kind of a perpetuum mobile, so kind of a cyclic mechanism, a vicious cycle. And this perpetuum mobile is actually most likely to explain, at least in part, the chronicity of the disease. Clearly, this self-amplifying mechanism underlies the pathogenesis of one specific pemphigus endotype, and many more genetic and environmental factors are involved here, many of which remain to be uncovered. Yet, this specific pathogenetic scheme points to novel therapeutic targets and suggests many innovative therapeutic approaches, such as inhibition, for example, of p38, which we recently found to be involved in mediating the effect of desmoglein 3 downregulation on p53 activity. And in parallel, the search for small inhibitors of ST18 is already on. And more immediately, this data may help better selecting pemphigus vulgaris patients, for example, for anti-TNF-alpha therapy, which has been shown to have variable effect in pemphigus vulgaris. Now, this vicious cycle obviously explains the chronicity of the disease, but also offers a new avenue for therapeutic intervention. Indeed, as you, I'm sure, all know, p53 is a very well-known activator of apoptosis, which is known to be involved in the regulation of cell-to-cell adhesion. And p53 works by antagonizing BCL2, which, among other things, prevent mitochondrial VDAC oligomerization. And given the fact that VDAC, which is a mitochondrial channel, is overexpressed in the skin of pemphigus vulgaris patient, we used an inhibitor of VDAC oligomerization, and by doing so, we were able to rescue the destabilizing effect of anti-desmoglein 3 autoantibodies, as well as of ST18 overexpression, as shown here, for example, using our famous dispace dissociation assay. And these inhibitors are now in advanced stages of preclinical evaluation. I would like at this point, just before closing, to very much thank the many people who have been part from some studies from our lab that I briefly mentioned here, especially the 3 members from my lab who contributed most to those studies, Ofer Sarig, Dan Vodo, and Sari Asaf, as well as our funding agencies, and you all for your very kind attention. Thank you very much.
Good evening, everybody. I'm Pascal Joly from the French Reference Center for Autoimmune Blistering Diseases. It's my pleasure to give this talk on the treatment of pemphigus. These are my disclosures with pharmaceutical companies. As indicated by our chairman, Professor Morel, in an editorial published in the British Journal of Dermatology, the combination of rituximab and corticosteroids has become the mainstay of pemphigus treatment, and I will try to explain why in the next slides. The first reason is that the combination of rituximab and oral prednisone is effective for the treatment of severe or recalcitrant cases of pemphigus. This has been demonstrated by the group of Professor Ahmed, who used the combination of multiple cycles of rituximab and multiple cycles of intravenous immunoglobulins, and by the French group, which used a single cycle of rituximab, which was given at a dose of 1 gram 2 weeks apart. And in fact, both studies provided very similar results, with a rate of complete remission on the short term, which was around 80%. The second reason is that rituximab used as first line allows to rapidly taper corticosteroid doses and to rapidly stop corticosteroids, which is a major goal in the treatment of pemphigus patients, while providing a high rate of complete remission. This has been demonstrated both in an academic trial, the RITUX-3 trial, which compared the combination of rituximab with a short-term corticosteroid regimen with a very rapid tapering of corticosteroid doses over 3 to 6 months versus corticosteroid alone with a progressive tapering of corticosteroid doses over 12 to 18 months. And in another clinical trial, which was sponsored by Roche, which compared the combination of prednisone with rituximab or mycophenolate mofetil. In the RITUX-3 trial, 98% of patients achieved disease control. 89% of them were in complete remission of corticosteroids at month 24 versus 34% of patients who were treated with prednisolone alone. And more importantly, you can see on the curves that at month 6, 70% of patients treated with the combination of prednisone and rituximab were already in complete remission of corticosteroids, resulting in a much lower cumulative dose of prednisone, 6 gram versus 18 gram, and a much longer cumulative duration of prednisone, which was 7-fold longer in patients treated with rituximab than in patients treated with the standard regimen of corticosteroids alone. In the Roche study, 40% of patients treated with rituximab achieved sustained complete remission of corticosteroids at month 12 versus only 9% of patients treated with mycophenolate mofetil, resulting in a lower cumulative dose of prednisone. As you can see on the relapse curves, patients treated with mycophenolate mofetil experience 7-fold more relapses during the tapering of corticosteroid doses than patients treated with rituximab. The third reason is that rituximab is a treatment which is generally well tolerated. Its main contraindications are recent severe infections, hypogammaglobulinemia, and immune deficiencies, recent solid cancers with high risk of metastasis, active hepatitis B or C, recent live vaccines, absence of vaccination against COVID, previous severe allergy to monoclonal antibodies, and pregnancy and breastfeeding women. Main side effects are infusion-related side effects, which are observed in around 20% of patients and mainly consist of hypo or hypertension, bronchospasm and fever, infections, which may be severe, and more rarely persistent hypogammaglobulinemia, which is mainly observed in infants and more rarely in teens and adults. The fourth reason is that first-line use of rituximab enables a high rate of sustained complete remission and likely a definitive healing of pemphigus in many patients. In a long-term follow-up study of the RETUX-3 trial, in which patients were treated with 2 grams of rituximab at baseline and 500 milligrams at month 12 and month 18, 65% of the patients maintained a sustained complete remission up to 7 years after the start of treatment, and among the 90% of patients who achieved complete remission of corticosteroids during the study, 76% of them maintained a sustained complete remission of corticosteroids up to 7 years after the start of treatment without any additional infusion of rituximab and without any severe adverse events from the 3rd to the 7th years after the start of treatment. Conversely, rituximab is much less effective when used as second line after the failure of a previous first-line treatment. When comparing the efficacy of rituximab used as first line versus second line, you can see on this slide that while the 3-year disease-free survival of patients treated with rituximab as first line was 75%, meaning that the relapse rate was 25%. On the contrary, rituximab was much less effective when used as second line, since the 3-year disease-free survival of patients treated as second line was 17%, meaning that 80% or 83% of patients had relapsed within the 3 years after the start of treatment. The fifth reason is that first-line treatment with rituximab is cost-effective. Indeed, as compared with high doses of prednisone, during the first 2 years after treatment, rituximab decreases the cost related to corticosteroid side effects, while on the long term, rituximab decreases the cost related to the treatment of relapse, which were much more frequent in patients treated with corticosteroids alone, resulting in the fact that after 7 years, first-line treatment with rituximab was around minus 7% less expensive than treatment with corticosteroids alone. And this discrepancy is expected to be further accentuated with the recent availability of rituximab biosimilars, allowing a reduction of rituximab cost from minus 30 to minus 50%. The sixth reason is that rituximab allows to use a personalized treatment strategy with maintenance infusions based on the evolution of biomarkers in patients who are still in clinical remission but with a high risk of relapse, in order to decrease the relapse rate, to increase the number of patients who maintain a sustained clinical remission, while retreating a minority of patients, thus avoiding systematic maintenance infusion of rituximab and a related risk of immunosuppression due to prolonged B-cell depletion. Indeed, when looking at the relapse curve under rituximab, we can see that around 20% of relapses occur during the first 2 years after treatment, and 20 other percent occurred from the second to the 7th year after treatment. We identify predictors of relapse in patients who were still in clinical remission, which were on the short term an insufficient decrease of anti-desmoglein antibodies after the initial cycle of rituximab, and on the long term a re-increase of anti-desmoglein antibodies. You can see that the use of these biomarkers for performing a maintenance infusion of 1 gram or 500 milligram of rituximab allowed a major reduction in the relapse rate, since 97% of patients who were managed according to these predictors did not relapse and were in complete remission at month 12. 93% of them were in complete remission off corticosteroids for at least 2 months at month 12. By reducing the 1-year relapse rate from an expected rate of around 20% to only 2.6%, while retreating only 39% of the patients. The seventh reason is that rituximab is also effective for the treatment of patients with PF. You can see on this slide that in a retrospective analysis of the evolution of 40 patients with PF that we compared with that of 70 patients with PV, the disease-free survival curves of PV and PF patients were very similar, indicating that rituximab is as effective in patients with PF as in those with PV. The great efficacy of rituximab in pemphigus leads in fact to questioning if there is still an indication for treatments other than rituximab and corticosteroids in the treatment of pemphigus. In particular, the indication of dapsone, which is very classical in PF, might be challenged by the use of rituximab. Indeed, the corticosteroid sparing effect of dapsone is often claimed, but has never been demonstrated. And in a retrospective study that we performed with the French group on 77 patients with PF, most of them being treated with dapsone and topical corticosteroids, after 3 years of follow-up, only 10% of the patients achieved complete remission, as compared with more than 80% of patients treated with rituximab. And importantly, 51% of patients presented severe side effects, including 2 deaths directly related to dapsone, and side effects led to treatment discontinuation in 23% of cases. Thus, the long-term efficacy of dapsone for PF is very modest, and its side effects are significant. Regarding intravenous immunoglobulin therapy, IVIG are effective for the treatment of recalcitrant types of PV and PF. Their corticosteroid sparing effect in relapsing PV is claimed but not demonstrated, and their use as adjuvant therapy as first-line treatment remains unclear. In a randomized control trial performed by the Japanese group, the time to escape, which was the time until the initial prednisone dose, which was 20 milligrams per day, was considered to be ineffective and had to be increased, was slightly longer in patients treated with 400 milligrams of IVIG than in the placebo group. To summarize, IVIG are a quite safe treatment, although there are some side effects. It needs hospitalization. It's an extremely expensive treatment. It's effective in some patients with recalcitrant types of pemphigus. The main advantage of IVIG is that this treatment is rapidly effective. It's not clear whether it allows to start treatment with a lower dose of corticosteroids and which proportion of patients would be controlled with a low starting dose of corticosteroids. Additionally, the efficacy of IVIG requires the infusion to be continued, usually 3 cycles, sometimes more. Immunoabsorption is a method to rapidly remove immunoglobulin from the circulation. The German group conducted a randomized controlled trial in which patients were treated with prednisone and conventional immunosuppressant with or without immunoabsorption. This study was prematurely stopped due to severe infection in the immunoabsorption group. The primary endpoint, which was the time to complete remission on therapy, was in fact not significantly different between the two groups, but the cumulative dose of prednisone was slightly lower in patients treated with immunoabsorption, and patients with more extensive PV and PF showed a tendency towards a shorter time to remission when they were treated with immunoabsorption. Regarding conventional immunosuppressants, which mainly include mycophenolate mofetil, azathioprine, and cyclophosphamide, their use is recommended in relapsing types of pemphigus, while most studies in the literature failed to demonstrate a major beneficial effect of these conventional immunosuppressants when used as first line. To end this talk, I recommend you to read the EADV guidelines, which have been published in the Journal of the EADV, which recommend as first-line treatment of mild PF, dapsone, topical corticosteroids, systemic corticosteroids, or rituximab. These guidelines recommend the use of rituximab and systemic corticosteroids for the first-line treatment of mild pemphigus vulgaris. And finally, these guidelines recommend the use of rituximab and systemic corticosteroids for the first-line treatment of moderate to severe pemphigus vulgaris and pemphigus foliaceus. Thank you very much for your attention.
Hello, my name's Dede Morel. I'm from Sydney, Australia. It gives me great pleasure to be joining the Guinea World Health Skin Day Congress for the 5th time. I hope you heard the introduction to all the speakers, because this is following on from a presentation by Professor Caterina Patazzi, which talked about the diagnosis and clinical features and pathogenesis of bullous pemphigoid. So my talk is about managing BP. The goals of managing bullous pemphigoid are to improve the patient's quality of life and hopefully to induce a medication-free remission, and if possible, medication-managed remission of the disease. The most common treatments for BP can be divided into topical steroids, anti-inflammatory antibiotics, immunosuppressive agents, immunomodulatory agents, and targeted treatment. There's also systemic steroids, which we try to avoid if possible. How experts are treating localized bullous pemphigoid was assessed from a survey of 65 experts from 27 countries. And it was found that for localized BP, most people could manage it with topical steroids, usually at a dose of 20 grams a day, and doxycycline was sometimes used in conjunction with that in a minority of cases. The therapeutic ladder for treatment of bullous pemphigoid has been published in the European guidelines in which I participated. The reference is shown there from 2022. For mild and moderate bullous pemphigoid, which means a bullous pemphigoid disease area index score of less than 20, or under 57 for moderate. The first choice in localized BP is potent or superpotent topical steroids on the lesions only. But in non-localized mild and moderate BP, the superpotent steroid should be applied on the whole body except for the face twice a day. If that isn't possible due to practical reasons or expense, then oral corticosteroids initially at 0.5 milligram per kilogram per day of prednisone is recommended. Second choice is doxycycline or dapsone. For severe bullous pemphigoid, BP dye scores over 57, the first choice is two treatments, superpotent topical steroids on the whole body, ideally twice a day, except for the face, or, if not practical or possible, oral corticosteroids at an initial dose of 0.5 milligram per kilogram per day. But if patients don't achieve disease control within 3 weeks on that dose, two other options may be considered. One, to increase it to 0.75 milligram per kilo per day, or two, to add superpotent topical steroids. There are several alternative choices of adjuvant therapies for patients who become corticosteroid dependent and can't get off them, or relapsing BP. And these are to combine the above treatments with an immunosuppressive conventional agent such as methotrexate, azathioprine, or mycophenolate mofetil. However, many of these elderly people are in poor general condition or have contraindications to immunosuppressive drugs, such as cancer patients or patients who are diabetic and prone to infection. And in those patients, other options such as doxycycline, dapsone, or omalizumab should be considered. For patients who are recalcitrant even to initial doses of up to 0.75 milligram per kilogram per day, you can combine them with those immunosuppressants, or you can consider using rituximab in combination, or omalizumab, dupilumab, IVIG, or immunoabsorption. In this landmark paper comparing oral and topical corticosteroids in patients with BP, published in New England Journal of Medicine, the findings for severe BP were surprising. The survival was higher in the topical than systemic steroid group by a significant amount, and severe complications were lower in the topical group, as well as efficacy being higher than for systemic corticosteroids. Despite these findings, in many countries, these superpotent topical steroids are very expensive, or labor costs of applying these all over the body twice a day is prohibitive. There are other drawbacks of topical corticosteroids: adherence to this by elderly people or those who take care of them, and systemic absorption from cutaneous application, as well as the development of bruising and skin thinning. Whether the steroids are topical or oral, there are many comorbidities that develop with chronic use. Therefore, baseline bone density is recommended, advice about dental management, bone protection, particularly making sure vitamin D levels maintained with calcium and vitamin D and bisphosphonates, control of blood sugar and or diabetes, salt restriction to avoid hypertension, giving exercise to improve muscle strength, and allowing UV exposure to improve vitamin D metabolism. Doxycycline was studied in a non-inferiority randomized controlled trial conducted in the UK and Germany. Group 1 received doxycycline 200 milligrams daily plus topical steroids, while Group 2 were randomized to prednisone 0.5 milligram per kilogram per day. The efficacy was found to be 74% in the doxycycline group versus 91% in the oral corticosteroid group at 6 weeks. However, there were much lower severe side effects in the doxycycline group compared to the prednisone group. The conclusion of the authors was that most patients could get better on doxycycline alone with topicals, and that they were safer than systemic steroids. However, there was a lot of crossover of patients, even at 3 weeks in this study, and therefore the results were somewhat mixed. For dapsone, there's no randomized controlled trial, just case series with estimated efficacy of 80%. However, elderly people have drug interactions and may have hemolytic anemia and other side effects which need monitoring in these with this drug. Rituximab has been studied only in retrospective case control series, comparing rituximab 500 milligrams weekly for 4 weeks and corticosteroids versus corticosteroids alone. They found a much higher rate of remission in the rituximab arm versus the steroid group, but this was not randomized. However, the risk of infection and 1-year mortality favored rituximab, but it wasn't statistically significant. There's also been a retrospective review of published cases of rituximab in BP, finding that more than one cycle was needed for 38% of the patients to achieve a complete response, and that 70% received a complete response, which is much lower than pemphigus studies. IVIG has been studied for moderate to severe BP in patients who couldn't tolerate immunosuppression or as an adjuvant treatment. Only one randomized controlled trial has been conducted, and it was an escape from tapering protocol design. It favored the IVIG in improvement of disease activity score, but missed statistical significance. There are various emerging targeted therapies for the management of BP. As you know, the immune responses are divided into type 1, 2, and 3. And within each, you have the innate and adaptive immune responses. Bullous pemphigoid is particularly part of the type 2 immune response, involving mast cells, basophils, and eosinophils, in addition to the T cell system. The key cytokines in each of these systems is slightly different, as you see here. And the physiological targets by evolution for the type 2 system was to fight off helminths or as a type of parasite. The type 2 cytokines have multiple critical roles in bullous pemphigoid. Interleukin-1 is involved in differentiation of T cells and increased expression of the itch cytokine interleukin-31. IL-4 and IL-13 are involved in immune activation and recruitment of skin tissue, blister formation, and interleukin-4 stimulates B cell proliferation and autoantibody production, as well as class switching from IgG to IgE. All three of these cytokines, IL-1, 13, and 31, induce sensitization and stimulation of neurons and neuropeptide release, contributing to itch. This itch pathway is very active in bullous pemphigoid, much more so than it is in pemphigus and other autoimmune blistering diseases. And the type 2 cytokines, interleukins 1, 13, and 31 are intimately associated with it. In addition to that, various inflammatory cells are drawn to the blistering in BP, including eosinophils, basophils, and mast cells. And treatments which target these and their mediators are therefore being looked into. This is the timeline of ongoing clinical trials for investigating biological agents for bullous pemphigoid. The first study that was to be developed was the Marigold BP study, which is being currently paused. The next one was the Ballad study, which is of efgartigimod, which is still ongoing, and the Liberty BP trial, which has reached its primary endpoint, which is a randomized controlled trial of dupilumab. The Marigold study is another anti-FcRn study of nipocalimab, whose development is currently on pause. The efgartigimod trial, or Ballad study, is looking at this particular FcRn inhibitor, which basically allows immunoglobulins to stay longer in the circulation instead of being destroyed in the lysosome. It's been looked into in a number of autoimmune diseases, I beg your pardon, and it's been approved for myasthenia gravis so far. In this trial design, the Ballad study, the patients, after screening with bullous pemphigoid of appropriate severity, were randomized to efgartigimod every week versus placebo up to week 36, where the primary endpoint was assessed, and then the patients were rolled over to an open label treatment. The patients were also started on corticosteroids and had to taper off these for at least 8 weeks prior to the assessment. The first readout from that trial, the pemphigus trial, was unfortunately not good, and therefore people are wondering what will happen with that efgartigimod trial for BP. Dupilumab is being investigated in an ongoing phase 3 trial called Liberty BP Adept. In this trial design, which is global, the patients after screening are given oral corticosteroids 0.5 milligram per kilo per day, and then randomized to either dupilumab every 2 weeks or placebo every 2 weeks, using the same dosing as is familiar for atopic dermatitis. After week 6, the patient's skin disease is usually under control, if not reepithelialized, and then a steroid taper occurs over a 10-week period. And then the patients are left to see how many of them stay in remission versus flare up again up to week 36, the primary endpoint. So the primary endpoint was a composite endpoint, quite difficult to achieve. It said it had to have a sustained remission at week 36, which consisted of the proportion of patients with improvement or reduction in average weekly itch score, the percent change in the BP dye activity score from baseline to week 36, and the total cumulative dose of corticosteroid from baseline, and the percentage change in PP-NRS. So far, it's read out with very positive results for the first part. This shows the composite of the primary endpoint. Starting over here at the right, there was a p equals 0.002 difference in absence of disease relapse after the steroids were ceased in the dupilumab arm versus conventional arm. There was a very highly significant difference between the absence of needing rescue therapy during treatment in those on the dupilumab versus placebo. Complete remission showed some difference, but it was not significant, and most likely because some patients had only fairly recently come off steroids in the placebo arm and therefore hadn't got a complete remission. Also, to achieve all 3 of these as a sustained remission endpoint meant that only 20% of the total who were benefiting from the dupilumab that you can see there, of the total cohort, were positive in all 3 groups, and only 4 of those on placebo were positive in all 3 groups, meaning that there was a huge statistical difference between the 2. A similar thing happened with each of the secondary endpoints, in which there was statistically a much better benefit with the dupilumab in every secondary endpoint, including greater than 90% reduction of disease severity, clinically meaningful itch reduction, reduction in severity of disease from baseline, reduction in itch from baseline, or days to complete remission with no steroids. So the primary endpoint was achieved, as explained, and all these secondary endpoints. What about side effects? Well, these were elderly people, and so there were always a lot of side effects in elderly people, 96%. For dupilumab, 96% for placebo. The ones that were most often observed in the dupilumab arm versus placebo were peripheral edema, arthralgia, back pain, blurred vision, hypertension, and asthma. And conjunctivitis was pretty low in the study, constipation low, upper respiratory tract infection, limb injury, and insomnia. There were no adverse events leading to death in the dupilumab group and 2 in the placebo group. There's a growing body as well of real-world evidence of clinical response against targeted therapies. These include dupilumab, omalizumab, and rituximab. But so far, the only one of these with any interest in studying it and providing it for a study is that of dupilumab. So in summary, there's a growing instance of BP in the elderly, which warrants expanded awareness, especially for its non-blistering presentations. The temporary or long-term use of systemic immunosuppressive agents is the mainstay of treatment for severe BP, but can be problematic in the elderly due to their comorbidities. Targeted therapies are very promising and just on the horizon, especially dupilumab, and others in development to address the underlying pathophysiology of bullous pemphigoid. So thank you very much for your attention. I hope to take questions in a short while.
Dear colleagues, good morning. My name is Caterina Pazzazzi. I'm a professor of dermatology from the Aristotle University School of Medicine in Thessaloniki, Greece. I would like to thank the organizers for their kind invitation to deliver this talk on the clinical presentation, pathophysiology, and diagnosis of bullous pemphigoid. These are my disclosures. To begin with the disease, bullous pemphigoid is by far the most common autoimmune bullous disorder. The annual incidence of bullous pemphigoid is worldwide increasing, ranging from 13 to 42 patients per million inhabitants per year. BP mainly affects elderly patients, and the risk increases up to 300-fold above the age of 90. It's a typical example of autoantibody-mediated organ-specific autoimmune disorder. In this disease, many triggering factors induce the formation of circulating and tissue-bound autoantibodies, which target adhesion structures of the skin and mucous membranes. There are associated diseases in patients with bullous pemphigoid, most commonly neurodegenerative diseases and psoriasis. And also there are associated medications such as gliptins and anti-PD-1 immunotherapy. Other triggering factors reported in the literature are exposure to UVA, mechanical, thermal, or chemical injury. In the spectrum of pemphigoid diseases, there are many clinically and immunopathologically distinct entities depending on the target proteins. So, bullous pemphigoid, which is the most common in the spectrum of pemphigoid diseases, is caused mainly by BP180 and C68 domain autoantibodies and BP230 autoantibodies. And a few words about the target antigens in bullous pemphigoid. To begin with BP180, the non-collagenous 16A domain of this antigen represents the immunodominant region, which contains the major epitopes recognized by autoreactive T and B cells. The NC60A specific peripheral T cell response in bullous pemphigoid is of a mixed T helper 1, T helper 2 type with T helper 2 predominance, and this is a knowledge very, very crucial for the new therapies. A subgroup of patients, though, in bullous pemphigoid reacts with different BP180 extracellular epitopes, but not with the NC60A domain. BP230, on the other hand, is an intracellular protein which belongs to the target protein family. The pathogenic role of BP230 autoantibodies remains controversial. BP230 autoantibodies may be associated with some atypical forms of bullous pemphigoid, such as the prurigoform, eczematous, or urticaria manifestations, and the localized type of bullous pemphigoid. The etiology underlying the autoimmunity to basement membrane zone antigens in bullous pemphigoid remains unclear. The breakdown of self-tolerance is mainly caused by regulatory T cells. There is an epitope spreading, and this is a phenomenon in which the target of cellular and humoral immune responses gradually expands from the initial dominant epitope to other epitopes on the same protein or to other proteins in the same tissue. Mainly in most of BP cases, there is complement activation by the autoantibodies bound to the basement membrane zone. There is a recruitment of granulocytes, and after the mast cell degranulation, the neutrophils attracted to the basement membrane zone become activated, and then they release tissue-destructive enzymes, including neutrophil elastase and matrix metoproteinase 9. Also, autoantibodies in bullous pemphigoid cause internalization of BP180 from basal cell membranes, reducing keratinocyte adhesion to the basement membrane. And keratinocytes also secrete interleukin 6 and 8 cytokines after binding to BP autoantibodies, potentially attracting also neutrophils and eosinophils independent of the complement system. So, the antibody-antigen binding activates simultaneously different molecular pathways rather than a single cascade. The mechanism of blister formation in bullous pemphigoid is complex, but the role of type 2 inflammation is very important. There is also a balance of contribution between complement-dependent and complement-independent mechanism. Can this may in part explain the clinical diversity in bullous pemphigoid? And this, from a recent article, is a scheme very well depicting the complex pathomechanism of bullous pemphigoid with the complement-independent mechanism and the IgG1 complement dependent cascade, in which we can also see the role of neutrophils, the role of mast cells, the role of tough helper 2 inflammation, and also partially the role of IgE. Clinically, bullous pemphigoid in its typical forms present with erythema, pruritus, and tense bullae. The pruritus is intense, the blisters are tense on the skin in the typical form, and with disease progression, these tense blisters can persist for several days before they rupture, resulting to crusts and erosions. Mucous membranes are affected in 10 to 20% of patients, with mostly only mild oral lesions in most bullous pemphigoid patients. There is also an early pre-bullous stage, which may present with solely pruritus, eczematous, or urticarial lesions. That's why there is clinical spectrum for bullous pemphigoid. This is a statement very well characterizing the disease. The clinical manifestations of bullous pemphigoid are protean and may mimic a variety of other inflammatory dermatoses. So we should differentiate bullous pemphigoid from dermatitis, drug reactions, scabies, cirrhosis, or pruritus due to renal or liver impairment. A significant percentage of patients with bullous pemphigoid, up to 20%, have no obvious bullae. So this is a typical example of a patient scratching herself with erythema, pruritus, dry skin, but no bullae, and this is a case of non-bullous pemphigoid. In cutaneous pemphigoid, the non-bullous pemphigoid form is well described in many of the textbooks dedicated to blistering disorders. A dermatologist should consider bullous pemphigoid when an elderly patient comes with unexplained itch without evident skin manifestations, or when an elderly patient does not respond well to return therapy and has persistent itch with recurrent eczematous lesions. And to proceed with the diagnostic procedures, on histology from a lesion of bullous pemphigoid, a recent lesion of bullous pemphigoid, we will see eosinophilic spongiosis, detachment of the epidermis and a subepidermal cavity in which we can find numerous eosinophils within the cleavage. A superficial also inflammatory cell infiltrate within the dermis may be found, characterized by varying degrees of intensity and consisting of lymphocytes, eosinophils, and neutrophils. But histopathology by itself, only by itself, cannot differentiate among various pemphigoid disorders. We should proceed with direct immunofluorescence from perilesional skin, or in case of non-bullous pemphigoid, from the lesional area. PP antigens are located at the dermal-epidermal junction, resulting in typical linear binding of IgG, IgA, and or C3, and rarely IgE or IgM at the basement membrane zone. Serration pattern analysis is a very helpful technique. This is performed on thin cross sections of perilesional skin biopsies using a conventional immunofluorescence microscope. In bullous pemphigoid, an N-serrated pattern with arches closed at the top is observed, while in epidermolysis bullosa acquisita, the immunoreactants demonstrate a growing grass or upstanding arm pattern with the arches closed at the bottom, forming a U shape, which is termed a U-serrated pattern. And in this initial paper, you can see which entities are differentiated by the use of N and U serrated pattern. The N serrated pattern on the epidermal side is commonly seen in bullous pemphigoid, while the U serrated pattern in EBA. Indirect immunofluorescence is performed using a monkey esophagus or normal human skin as a substrate, and we can see the typical linear anti-basement membrane zone reactivity. The use of human salt split skin, as you can see here, allows the differentiation of pemphigoid autoantibodies in those who binds to the epidermal part of the blister or to the dermal part of the blister. And when we see it on the epidermal part, it's usually BP180 and BP230, and we have bullous pemphigoid. The ELISAs, the enzyme-linked immunosorbent assays, are very useful techniques to detect the circulating autoantibodies. ELISA is based on the immunodominant parts of the recombinant antigens. It's widely available for the detection of circulating IgG against BP180 and C69 and BP230. Anti-BP180 and C68 correlate with disease activity in most patients with bullous pemphigoid. Also, evaluations of serum autoantibody levels are recommended for the follow-up of patients. And lately, multivariant ELISAs have been introduced to enable a parallel identification of different autoantibodies on a single ELISA plate. There are also biochips. Biochips are miniature substrates that can be assembled together in a mosaic in a single incubation field of a laboratory slide. And with this approach, we can simultaneously test multiple autoantibodies against several antigens in a time and serum-saving manner. To summarize, for bullous pemphigoid diagnosis, we have the clinical picture with blisters and erosions or urticarial plaques and erythema predominantly at the skin. Subepidermal blisters with eosinophilic, lymphocytic, or neutrophilic infiltrates in histology. Linear deposits of IgG and complement in direct immunofluorescence of the perilesional skin. Blister roof staining on salt split skin by indirect immunofluorescence, and detection of BP180 and BP230 autoantibodies by ELISA. And for assessing or evaluating the severity of BP, we have also this tool, bullous pemphigoid disease area index. And there are studies in which we have also defined how to recognize mild, moderate, or severe diseases, bullous disease. When it's less than 20, it's mild. When it's more than 20 and less than 57, it's moderate. And when it's more than 57, it's severe disease. So, to sum up, bullous pemphigoid is the most common autoimmune blistering disorder in the elderly. BP180 and C16A is the most common target antigen. The pathogenesis of this disease is multifactorial with a very important role of TAF helper 2 inflammation. There are bullous forms and non-bullous forms of bullous pemphigoid. Diagnosis is based on clinical picture, direct immunofluorescence, and serological tests, and the treatment horizons are based on the cytokines involved in BP pathogenesis. And with this, I would like to thank you for your attention, and I'm ready to take your questions. Thank you.
Hello, I'm Professor Frederick Coe. I'm head of the department of Avicenne University Hospital in Paris, France. And I will speak today about epidermolysis bullosa acquisita and its link with African population. I have no conflict of interest regarding this presentation. Epidermolysis bullosa acquisita is a subepidermal autoimmune bullous disease defined by the development and the circulation of autoantibody directed to collagen 7. It's a very rare disease, and its incidence has been evaluated between 0.2 to 0.5 new cases per year and per inhabitant. And it's around 3% of the group of autoimmune subepidermal bullous disease. The clinical manifestations are various. You have several presentations: the mechanobullous form or classical form, the inflammatory form, the mucous membrane pemphigoid form. And regarding the pathogenesis of this disease, so collagen 7 is a component of the basement membrane zone. It's composed of 3 identical alpha chains, and each chain is composed of a central collagenous segment, and outside this collagenous segment, 2 non-collagenous domains, NC1 and NC2. And the collagen 7 is a major component of anchoring fibrils and permits the binding of epidermis to dermis. Even if the patient have a very low titer of antibody against collagen 7, in fact, these autoantibody are pathogenic, and it's the work of David Woodley, who was able around 20 years ago to demonstrate the pathogenicity of this antibody. He injected a human antibody against the NC1 domain of collagen 7 in mice, and the mice developed blisters. You have also a very rare spontaneous EBA in dogs, which could use in the future for therapeutic research. So the first form of EBA is the classical form. It's occur around 50 years, but this form can develop in baby or in elderly, and its incidence is increased in Africans, and I will explain later why. So the manifestation, usually the disease starts with skin fragility, then the patient develops small blisters and erosion over the trauma-prone surfaces like knees, elbows, or hands and feet, and the lesion heal, letting scars and milium cysts. The mucous membrane involvement is rare and usually the oral cavity, and you have no urticarial lesion. Here you have a patient who has this erosion. Here you can see on the knee, which are typical of EBA, and also here on the feet. And in this patient you have this cigarette paper scars, and you can see on the knee. You have absence, you have anonychia, absence of nail here, and you can have some cysts like here that you can see on the picture on the left on the feet. And also in this woman you have this erosion, scars on the joints that you can see here or here and here, and you have also absence of nails for some fingers. So the second form is the inflammatory form. It looks like a bullous pemphigoid with some inflamed skin and urticarial lesion. You have some widespread vesicle and blister on the trunk, on the neck, on the face, on the folds, on the extremities. And usually in this type of patients, the first diagnosis is suspected is bullous pemphigoid. And as you can see on the picture on the left, it's occur in Africans. The third form, it's the mucous membrane pemphigoid form. So it looks like an MMP with this some erosion scars on mucous membrane. So in the oral cavity, you can have erosions on the tongue, on the lips. In the nose, you have a crusted rhinitis. In the upper esophagus, you have strictures of the first third of the esophagus. For the eye, you can have inflammation of conjunctiva, fibrosis, ankyloblepharon, and blindness. For larynx, you have erythema and stenosis. For genitals, you have erythema and synechia. And for anus, you have erosions. Here you can have some lesion here on the mucosal part of the lips, or here on the buccal mucosa, or here on the tongue, and here you have some inflammation, some redness on the gums. For the eye, here you have some blepharon. You can have also blindness. It's in a patient of our department. She's from Senegal, and she's completely blind for her left eye. Here you have some erosion on genitals, and here you have some erosion on the anus. Here you have some inflammation in the esophagus, and you have a stricture here that you can see in the esophagus, and you have also in the ENT region, you have on the epiglottis an erosion, and you could have stenosis under the larynx. The fourth form is a Braunstein piriform. It's a misleading form because the patient usually have this crust and no blister on the scalp or the face, the neck, and the upper trunk. And it's sometimes difficult to perform the diagnosis. And here it's a patient we had to manage in our department, and she arrived with this very large crust on the scalp. She has only this lesion. She was coming back from Africa, and in the beginning we thought it could be a parasitic infection or a tumor. And as you can see, under the crust you have an erosion, but you have no splitting on the edge. So we spent several months here before to perform the good diagnosis, which was Braunstein piriform. And finally, you have IgA and IgM-EBA. So IgA is usually adult with vesicle blisters and urticaria, and they have intense pruritus, rare scars and milium cysts, and in 30% of patients, they have oral cavity involvement. You can have some very rare cases of severe ocular involvement. And IgM-EBA is the classical mechanobullous presentation, and it could occur in patients with a gammopathy, an IgM gammopathy. Here it's a woman I follow with this classical form of EBA. She has an IgM peak, and this IgM peak has an activity against collagen 7. So regarding the diagnosis, you perform 2 biopsies, one for standard pathology and one for direct IF. The standard pathology shows a subepidermal blister, and usually you have a scarce inflammatory infiltrate. You have few neutrophils, few lymphocytes or eosinophils. And the direct IF show linear IgG immune deposits on the basement membrane zone, and sometimes you have also C3, IgA or IgM. So both tests permit to perform the diagnosis of autoimmune subepidermal bullous diseases. But if you want to be sure that the patient have an EBA, you need to be able to demonstrate that he has antibody against collagen 7, and you have to perform specialized tests like indirect IF, immunoblotting, or immunoelectron microscopy, or serration pattern analysis, or biochip. So to help for the positive diagnosis of EBA, we have published several years ago an article in the British Journal of Dermatology, and in this article we drew a diagnostic algorithm for the diagnosis of EBA. Of course, if you have antibody against collagen 7, it's easy. You are sure that the patient have EBA, but if he has no antibody against collagen 7, which is the majority of patients, you need to exclude other autoimmune subepidermal diseases. Regarding the treatment, you have on the left the long list of treatments that you can use in EBA. You have some national guidelines for the treatment. Usually for the mild EBA, you start with colchicine or dapsone, and if it's not efficient, you add oral corticosteroids. And for severe patients, you can start with oral corticosteroids and IVIG or rituximab. There are for the moment no international guidelines for the treatment of EBA. So regarding the link between African population and EBA, in fact there was a large EBA study in the US by Gammon a long time ago, and it shows that 62% of his group of patients with EBA were black patients of African descent. In our department, we perform a study, and we found also that black patients were very, very frequent in the EBA group. So we perform a retrospective study, and we show first in the period of 2005 to 2009 that you have another representation of black patients with EBA. So it means that 54% of EBA and 3% of other non-EBA autoimmune bullous diseases were black, and the difference was very, very significant in terms of statistics. And also that you have 54% of black patients and 3% of white patients had EBA in our series, and also the difference was highly significant. And then we add to this group more patients, more black EBA patients, and we try to understand why there was this link. So first we show that the origin of the patient was in majority Benin, Togo and West Indies. The presentation was a little different. It was more an inflammatory form in young patients with involvement of the head, the trunk and the mucous membrane. And we did analysis of HLA, and we show that HLA DRB1 1503 allelic frequencies were 50% for the African patient, and it was significantly higher than the control population. So it means that in fact these patients have a special HLA group which permit to the disease to develop. In conclusion, there are several presentations of EBA. The diagnosis is difficult, and to be sure to confirm it, it requires specialized tests. And also that EBA is more frequent in black-skinned patients due to a genetic predisposition. And also that EBA should be systematically suspected in a black patient developing subepidermal autoimmune bullous disease. Thank you for your attention. scars and medium cysts. The
out there can hear us, or do we have to be enabled?
This is and it would be difficult to diagnose. Hello? So I don't know if we have any questions.
Will we receive any questions on the chat or?
Hi, good morning. I think that a lot of people are still early morning seeing patients. I think they're going to replay some of the talks, but in case there are some people listening, I put a question in the chat for Jose, which is, do you think that in the future there will be any substitution for invasive skin biopsies for the diagnosis of autoimmune blistering diseases, or any kind of live dermatoscopic type of, or what do you call them? What's the other one that they're using nowadays for the BCC diagnosis? Where
Confocal microscopy.
yeah. Would you care to comment about that, please?
I don't have a lot of experience. We are doing a lot of research in my department with confocal microscopy, with a group of Susanna Puig, but we are doing mostly in tumors, in oncology, and when we try to do it in inflammatory diseases, it's not as reliable as regular histology. Probably in the future it will help us, but anyway, I think that histology on the skin is not so aggressive, so doing a punch biopsy is not like doing a deep biopsy that we would need, for example, for morphea or other diseases. And the problem, I don't see this would work very well in difficult sites like the mouth or the genitalia, where we still need a punch. So I think we'll work with the same tools in the futures.
Okay, that's great. And Katerina, can you turn your camera on if you're still there? And you too, Jose?
La diffusion en direct est en cours.
We have the camera.
We have the cameras open, yes.
We see you.
Oh, I can see. I can't see you though.
We see you. I see both of you.
Oh, really? Okay.
Me too. I can see you both.
In case there are people listening to us, so it appears to be early morning in Europe, and perhaps some people are in clinics. So if this is being recorded, perhaps it'll play again later. We just finished listening to 7 very elegant presentations all about autoimmune blistering diseases by world-leading experts covering pemphigus, pemphigoid, and EBA. And we have live with us today Professors Jose Mascaro from Barcelona, Spain, and Professor Caterina Pazzazzi from Thessaloniki in Greece. whose talks were amazing. If you get the chance to listen to them, please do so. And Katerina gave an elegant summary of the clinical manifestations of bullous pemphigoid and the pathogenesis, which is particularly complex. Katerina, in my talk, I touched on some early results that have come through on the efficacy of dupilumab in bullous pemphigoid. And in your presentation, you spoke a little about the role of type 2 inflammation in BP.
Yeah.
Do you think that the proportion of involvement of this is going to be a game changer for our patients with bullous pemphigoid?
Yes, I do so, and there is also, as you saw us in your fantastic talk, there are encouraging data from the ongoing clinical trials regarding dupilumab in bullous pemphigoid. But I think that as we presented, and we all know, as the pathophysiology is quite complex, a major role is on
La diffusion en direct s'est arrêtée.
inflammation. So dupilumab may help, but not, I think, in all the cases as monotherapy. It will be combined, at least at the beginning, with
La diffusion en direct est en
systemic
cours.
steroids. But still, it's a very, very promising treatment.
I think the live streaming went on and off while you were giving your answer. Would you mind just saying again what you think about the game-changing effect of bullous pemphigoid, of dupilumab in bullous pemphigoid from the recent trial?
Yeah, I think that it seems to be an effective treatment, a safe treatment, a steroid-sparing treatment. It might help all of these elderly patients who are really suffering from the deleterious effect of systemic steroids. But of course, it cannot be monotherapy for all the cases. I mean, it should be, at least at the beginning, I think, combined with lower dose of systemic steroids. So it will be a game changer, but we need more data. We need to try it in more cases, but still, it's a very promising one.
Great. Jose, do you have any personal experience from the trial or from using dupilumab in any of your complicated?
Yes. We had experience. We have treated maybe more than a dozen patients in my department, and we recently published a retrospective study of all Spain, more than 100 patients, and we had really very good results. So the impression this is it's probably the future, because it's a medication where we are familiar, because we are using in atopic dermatitis. It's very safe and convenient for the patients, and I think it's probably the future, because we want drugs that are safe and effective in this type of population. I had some patients who relapsed, but anyway, I think the treatment really works, and this has been shown, as you brilliantly show in your presentation with the clinical trial, that really I think the results in real life are better than the clinical trial. That's my impression.
That's interesting.
That happens many times. That clinical trials are so restrictive. Then, but and with many treatments, we have better results in real life. The clinical trial that really
I've had a wonderful
I think the
fellow with my
results in
department
real
from
life
Ireland, and
are
she had
better than the
experienced this
clinical
poor
trial.
lady in Dublin
That's my
who
impression.
was stuck in ICU for nearly 6
That
months
happens
and had
many
tried
times. The
rituximab,
clinical trials
IVIG,
are so
methotrexate, all
restrictive.
these cytotoxic drugs. And in the end,
with many
this
treatments,
BP patient
we have
only
better results
responded
in real life.
to combination of omalizumab that she was already on, but not fully responding to as well.
She had
And
experienced this
dupilumab,
poor
and with
lady
these
in
agents,
Dublin
this
who
patient was able
stuck
to
in
get off all
ICU
the
for nearly
steroids
6 months
and
tried
these other toxic drugs that hadn't
IVIG,
worked, methotrexate, all
then it
these
was the
cytotoxic
addition
drugs,
of the dupilumab
and
that
in the
finally
end,
got
this
her better.
BP patient,
And she was
only
a really severe
responded
case.
to combination of omalizumab that she was already on but not fully responding to as well, what's left, and dupilumab, who doesn't have these agents, complications in real life, tell patients that we have are those with all these other toxic drugs that hadn't worked, and then so addition of the dupilumab. Did you have any further comments for the audience? Because at this time there's no one asking tricky questions of us.
No, I don't really have any question. I think all the presentation were great. The sound was not great at first, but then it was perfect. So I could follow all your presentation, and also Frederick's and Pascal. They were a very nice presentation. I think there was a very nice symposium.
Yes, and I think people in Africa can't travel very easily to other places, and then to have to pay money to listen to educational talks. It's unique that this is all free for them, and quite tricky that Ibrahima has had to put all these great international talks together for people to be able to listen to with low budget. You know, it's pretty amazing to me. And I'm really grateful to you for giving up your time today at your busy jobs and being available to record these talks and then be there to answer questions. And we will be receiving questions after the fact, and we will be able to respond to them by writing replies, I understand.
Okay.
So thank you for coming, and hopefully next year we'll have the streaming part of this will be more smooth. But thank you again, my friends.
Thank you very much, Sede, for the invitation.
Thank you for organizing together with Ibrahima Tauri. And
thank you.
Have a nice day and a nice week.
You
Bye-bye.
too.
Bye-bye.
Bye-bye. Thank you.
Bye.